Over the last year, there have been several additions to the social and medical services available to patients in the out-of-hospital environment. As first responders, we don't always use the many non-emergent resources at our disposal. We hope this information will encourage you to use these resources to address your patients' needs. At first glance, some of these services seem to overlap. However, each one has a specific place in the care of patients in the field. This video is designed to help the EMS and first responder organizations understand the mission of each of these services and how to refer patients to them. We will be covering Adult Protective Services, APS, Mobile Outreach Team, MOT, Healthcare Link, and Community Health Paramedicine, or CHP. My name is Pauline Van Meurs. I'm the project manager for the Williamson County EMS Community Health Paramedic Program.
My name is Linda Wright. I'm the Resource and External Relations Specialist for Adult Protective Services Region 7.
Linda, can you tell me a little bit about what is the mission of the Adult Protective Services Program?
Sure. Our mission is to protect vulnerable adults, and that would include adults that are elderly, which is 65 or over, or adults with a disability, a physical or mental disability, where they have a substantial impairment. And we investigate, we identify the abuse, neglect, exploitation, the problem, and we offer services to prevent the abuse, neglect, exploitation.
Linda, can you tell me a little bit about what constitutes this abuse and neglect, and what was the other term that you used?
Exploitation.
Exploitation, yes, thank you.
So Adult Protective Services investigates abuse, which would be, it could be physical abuse, sexual abuse, or emotional verbal abuse. Neglect, which could be physical neglect, medical neglect, or mental health neglect. And exploitation is financial exploitation. The majority of our cases that we get and investigate are self-neglect.
So what actually constitutes an abuser?
Okay. An abuser, in our terms, is considered an alleged perpetrator, and that would be someone that has an ongoing relationship with our client, oftentimes a family member, possibly a caretaker, or someone who has an ongoing relationship with someone. So it wouldn't be like the door-to-door salesman that's the scam artist. That's not something that we would be able to investigate as far as exploitation goes.
But it doesn't also have to be a family member. It can be someone that was hired to take care of the client, or it can be someone who is constantly in the house for whatever reason.
Right. That has that ongoing relationship has been established.
So who is supposed to report abuse?
Texas law states that everyone is a mandatory reporter. That includes neighbors, friends, family, passerbys, EMS, the fire department, the police department, APS. We're out there and we see something, so.
And if we are together on the scene with fire and EMS, do we all have to file a separate report because we were all there and we all saw it?
Not necessarily. As long as we get the information conveyed to the hotline, it could be one person, one agency, and they can put the information that they have from the other agencies, or list them as a collateral contact in the intake report. But it's ideally just one intake report.
So it would be a good idea then for a little discussion to take place on the scene as quickly as appropriate as to who's going to, whether the medic or the firefighter is going to file the report, and then maybe one or two names with contact information as a collateral reporter.
If that's possible, but yeah, the whole collaboration aspect would be ideal. They're seeing.
So as opposed to the nurse at the hospital necessarily being the one to always call this in, you do get useful information about what circumstances the patient's living in, if you get that call from fire department or EMS.
Exactly, because one of our requirements is to make a home visit and do a face-to-face contact.
So it might be useful for the person reporting, let's say, to provide a personal phone number rather than their station phone number if they only work every 3 days, especially if they're concerned that this person needs to be seen sooner rather than later.
That would help if
Yeah.
they're willing and able to do that, because sometimes if they're off duty, it may not be convenient. It's usually a quick call just to find out what's going on.
And once you get the report, what kind of happens next?
Okay, so a call is made to the hotline, and preferably if, say, an EMS personnel is making the call, if they can give as much information as possible that helps us in our investigation, name, date of birth, social security number, if they know their medications that they're on, diagnoses, what they observe in the home if there's concern. Are the utilities working? Is there food? Do they have their medication? Just, basically, are their basic needs being met? Also, if there's concerns about something that's unsanitary, like hoarding, problems with roaches or rats or bed bugs, we get those kind of cases.
Yeah,
So the call is made to the hotline, and the statewide intake worker, based on the information that they have, that's why it's good to have as much information as possible, will prioritize the case to priority 1, where the worker needs to go out within 24 hours, or priority 2, which would be within 3 days, or priority 3, which is 7 days. And priority 4 is 14 days. And the reporter is often called just to get some follow-up information and make sure we're addressing everything that's in the report, because sometimes there's more information that the intake worker may not have obtained. So we want to, make sure that their basic needs are being met, because oftentimes we may change the priority based on that information. And once we identify what the problem is, as a caseworker, we can offer services such as a simple referral to home health care, making sure that they have a doctor that they can go to, because you need the doctor before you can have the referral for home health care. We do help with immediate emergency needs, like if they're out of their life-sustaining medication, if they need food, if their utilities are cut off. That's something we can help with after we do an assessment of their financial situation and identify the underlying cause. Because when we assist as far as with our funds, it's usually like a one-time.
It's not designed to replace ongoing care or primary care.
Exactly. And sometimes it may just be, they may need just a referral to Meals on Wheels, or they might need help with money management, like a referral to a money management program.
Sounds like there's a lot of overlap between APS and community health paramedic and the mobile outreach team. So I just want to make a little bit of a clarification, is that your major goal is to assist people that are probably in that abuse, neglect, and exploitation where it's become somewhat emergent. And what are some of the indicators that has occurred?
As far as abuse, neglect,
that it's become somewhat emergent. I know abuse is something we always want to report immediately.
Right.
Same thing with the suspicion of financial exploitation. But what are some of the signs in your mind that a patient's got enough of an issue of self-neglect that we really need to be considering calling?
Okay. When there's concerns about weight loss, malnutrition, dehydration, those are more serious. But hygiene declines, like they're not changing their clothes, they have body odor, not bathing, and not taking their medication, not eating, don't have food.
And is it ever possible that a person can decline your services? Under what circumstances can they decline your services?
Definitely,
even if we report?
They do have rights, but if a person has capacity and they do not want our services, they
can decline.
Exactly, yeah.
Let's say that there is a patient that EMS or fire responds to, and they know that there has already been a report made. Is there ever circumstance where it's appropriate to make a second or even third report?
Oh, definitely. If they have that communication with the caseworker and can have that kind of communication is one way. But if it's something more immediate, they can always call the hotline, and the worker will take the information and either do what's called an INR, an inquiry and referral, and get that information fielded to the worker. Or if it's more immediate, new allegations, then they'll generate a new intake report. And it'll go to the assigned worker who's already working the case.
Okay.
But definitely there's no problem with calling.
Good. I know that we can call the hotline, and that's especially important if we feel that the patient needs to be seen pretty quickly.
Right.
Is there another means by which we can report if it's a little less critical?
Yeah, so we have internet reporting. Now the 1-800 number, I'm going to just say it is 1-800-252-5400, and that's available 24/7. You'll have more luck if it's after the 8 to 5 hours. And then the internet reporting is addressed by the statewide intake workers, but sometimes they don't get to it till after hours. So a worker's not going to get that information right away.
So that might be an appropriate means of referral if you know that your patient is already safely at the hospital and it's okay for it to take till the next day to be looked at.
Yeah, definitely.
Thank you very much.
All right, thank you.
I'm Annie Burwell with Williamson County Mobile Outreach and Emergency Services.
Annie, can you tell me a little bit about how Mobile Outreach Team came about?
So the Mobile Outreach Team came about 10 years ago when the Commissioner's Court decided that there were too many people winding up in jail or in emergency rooms due to mental illness, that they could be better served by a team that handles crises primarily in the field.
What kinds of patients does the MOT take care of?
MOT primarily deals with people who are struggling with suicidality or homicidality or psychosis. Generally, the patients that we come into contact with are in some sort of crisis related to mental illness. It could be a one-time event or it could be due to chronic mental illness.
How many patients do you see?
We do about 4,000 encounters every year.
It's a lot of patients.
Yes.
Annie, how does the typical MOT referral flow?
So from the EMS side, the best process to use would be to use your radio to contact dispatch and request the next available MOT. The MOT will then call that unit's cell phone. That's usually the fastest way to do some more in-depth conversation about what's going on. And then between the EMS crew and the MOT, they can figure out, does the MOT need to come out, right now, this instant, or is this a situation that needs follow-up in the next hour or two? Generally, we are pretty prompt at getting to the scene, but there are times when we'll get a request from Gerald and we'll be in Liberty Hill, and so it may take us a little while to get out there. If you feel that the patient is safe and you've medically cleared that patient, then you can go ahead and clear the scene, and then we'll follow up with the patient or with the family as soon as we get there. And then if you would like some information about what happened as a result of the call, we're happy to provide that to you so that you feel like the loop has been closed and you know what the situation, how it was resolved. If we're on scene and we find that someone needs involuntary hospitalization for psychiatric reasons, so they're suicidal or they're homicidal or they're psychotic, then we're going to probably need to involve CIT, the Crisis Intervention Team with the Sheriff's Department. Because in Texas, only a law enforcement officer can issue an emergency detention and place someone in a psychiatric facility against their will. So at that point, we would request a CIT deputy. There will be times when it will be kind of confusing because once CIT issues the emergency detention, the receiving hospital may also request medical clearance, which would require EMS to transport that person to an emergency department. So those situations vary depending on the receiving hospital and the medical needs of the patient that we're in contact with. So about 80% of the patients that we come into contact with, we're able to arrange outpatient services, either psychiatric care or counseling or medication.
Can you tell me how to handle the purple form?
Okay, the mysterious purple form was devised several years ago in an attempt to improve communication between law enforcement professionals on the scene and MOT or CIT or hospital social worker who's working with the patient during the medical clearance process. So a typical or a good use of a purple form would be if a patient had intentionally overdosed and EMS responds to the scene. Law enforcement also responds to the scene. EMS is asked and provides the purple form. It should be on all the ambulances. MOT also carries purple forms. But then what happens is that the law enforcement personnel, whether that's a city officer or a county deputy, then fills out the information that is of concern on scene. So, for instance, the officer would write, intentional overdose, previous history of suicide attempts. We believe that the person has taken, 50 pills of such and such. So that form is filled out by law enforcement. It is handed off to EMS and stays with the patient. So EMS transports the patient and the purple form to the hospital. That form then is placed on the chart. And the great thing about that form is that it may take several hours or several days for someone to go through the medical clearance process. And with shift changes and change in stories and things like that, some of that information is lost. So it's really helpful for us when we go back to do a mental health evaluation to have that initial information that's on the purple form. So when we're requested to come back to the ER or to ICU or on the floor to evaluate the patient, we then see the purple form that EMS has so carefully gotten to the hospital for us, and then we can have more information about what really happened on scene.
And how many team members do you have at MOT right
We
now?
have 10 MOTs.
So are they round the clock?
We are around the clock. We do have a dark out period for the jail and for hospital emergency departments between 3 a.m. and 7 a.m. But field calls are 24/7.
Thanks very much.
Thank you. You're welcome.
I am Elena Biasotti, case manager with Williamson County Healthcare Link.
Elena, can you tell me a little bit about Healthcare Link and how it came about?
Healthcare Link is a program that began in September. We see a group of individuals who are high utilizers of emergency services who have a mental health as well as a chronic disease component.
And how many patients do you see in an average month?
We have 20 patients currently enrolled, and we space them out through the week and usually see 2 to 3 patients a day.
And how many people are currently on the Healthcare Link team?
We have 4 people on the team, 2 case managers, 2 paramedics.
How would field personnel refer a patient to the Healthcare Link team? What happens after the patient has been referred to you?
Once the patient has been referred, we will look it up in EMS systems by our paramedic, and then I will walk over to MOT and have them look up the patient in theirs. And then we also have contacts with emergency rooms here in Williamson County. Once we verify whether or not they've had 5 or more visits or emergency services encounters, then if they qualify, we'll enroll them into our program.
And once they're enrolled, what kinds of services do you provide for these patients?
We'll visit the home for initial intake, visit with the patient, observe their environment in which they live in, get an idea of what their economical status is, and then what are their barriers to care? Do they not have insurance? Do they not have transportation? Are they isolated? What is it that's causing this? From there, we will begin to set up goals for these patients. What do they want to address first? What are their needs? And then from there, we start working with the patient, whether it's just transporting them to a doctor's visit, or if it's helping them enroll in Medicaid or get their papers for Medicare or disability.
Thanks.
You're welcome.
Okay. So Annie, can you tell me what would then be the specific differences between the MOT and Elena's discussion about Healthcare Link?
Sure. So consider mobile outreach team an emergency mental health response. So if you have a patient or a client who is suffering from a mental health crisis, that's when MOT needs to be contacted. If you have a patient who has medical concerns in addition to behavioral health concerns and needs ongoing case management, that's where Healthcare Link can be most helpful. We're both housed in the same office, and we move patients back and forth, but MOT is more for an emergency situation. Healthcare Link is an ongoing service.
Well, thanks very much.
You're welcome.
Healthcare across America is changing, so Williamson County Emergency Medical Services is changing with it. While the EMS focus has always been and will continue to be emergency care, Williamson County EMS also has begun a community health program, or CHP, to provide community outreach for underserved patients, largely in rural areas, who have utilized emergency services in the past for their regular care.
The community health program's mission is to reach patients who are underserved and get them a primary health service so that they can maintain their health and not wait for an emergency to get them to a doctor. The goal is then to reduce non-emergency ambulance usage as well as reduce hospital admissions by following up with patients before they reach a critical point. When we go into patients' home as community health providers, we do a lot of education. Sometimes that involves helping them organize their medications and educating them about their medications. We do home safety assessments, and then we can have someone come in and install grab bars and non-slip shower mats to prevent falls. We test patients' blood sugar levels and assess their blood pressure. In our congestive heart failure program, we'll be doing different blood tests to ensure that the patients are improving and having contact with their doctors to see if there needs medication changes.
The program started March 1st, 2014, and we have 35 patients enrolled. Potential patients are identified through referrals from the area hospitals, the Williamson County and City's Health District, the mobile outreach team, and also through identification of high EMS utilizers. Patients cannot be referred from the public at this time. It is estimated that there were approximately 2,000 non-emergency, low-priority calls to rural areas in 2013. This program is designed to reduce those calls and free ambulances to address emergency calls. The team is comprised of the program coordinator and community health paramedics. They work with Williamson County and City's Health District navigators who assist in finding medical resources for the patient. They also work with health clinics and physicians. Many of their patients are isolated from family or others. They provide the patient with education and support to help them stay healthy. The CHP program is a grant-funded project designed to decrease high utilization of emergency services such as EMS, fire, and emergency rooms. The program began on March 1st of 2014 with 1 unit and 4 community health paramedics, and now has 2 units and 9 community health paramedics. The goal of the CHPs is to identify the reason for the patient's high reliance on emergency services and provide assistance in directing them to the right service in the right place at the right time. For some patients, the reasons for 911 and ER use is a lack of access to adequate primary care. For other patients, it's the preventable escalation of chronic illness requiring multiple hospital visits. The community health paramedics are trained to identify barriers to health and care and provide the appropriate referrals, education, or medical treatment for the patient. Currently, the program has between 25 and 40 patients at any given time. During the initial visit, the patient, their home, their medications, their diet, and their lifestyle is carefully evaluated. Once these evaluations are completed, a plan is developed to manage the required changes and therapies. Once the patient is on track, they graduate from the program. This can take anywhere from one visit to several weeks, depending on the patient. Please consider the following types of patients for referral. Patients that you run on frequently. Keep in mind that if you run on them frequently, other crews probably do as well. Also consider patients that first responders report to you as frequent lift assist clients or medical assist clients that may not require transport. Currently, we enroll patients with 3 or more 911 and/or ER activations. Even if they don't meet the actual enrollment requirement, we can put them on a watch list, and when they activate through EMS again, we will receive a report from the charting system by the next day. To refer a patient to CHP, EMS personnel can use the special report feature in EMS charts. There is a checkbox for community health paramedicine. Please provide the patient's phone number when referring them to us. Also, please make sure that we have the correct spelling of their name and date of birth and social security number on the chart that you are attaching to the special report. If the patient does not have a phone, please indicate that in the comments. Finally, we can best help the patient if we know why you are referring them to us. Give us as much detail as possible about the situation you feel we should look into. For example, the patient does not remember to take their medication or does not understand the use of their medication. Or the patient falls all the time and needs help with prevention. Once we receive the referral and enroll or place the patient on the watch list, you will receive an email letting you know that we have received your referral and what the disposition is at this time. Once the patient graduates from the program, we will let you know and will ask you to let us know if they need further assistance in the future.